This is the Chairman's Corner at the Perspectives in Lung Cancer in Amsterdam. My name is Peter Postmus. I'm a pulmonologist and working in Amsterdam. And my co-chair is Professor Scagliotti.
Hi.
You may introduce yourself as well.
Hi, I'm Giorgio Scagliotti. I'm Professor of Medical Oncology at the University of Torino in Italy, and I'm the co-chairman of this meeting, Perspective in Lung Cancer, that we are running in these 2 days in Amsterdam.
So this is the 15th meeting, so it has a very long tradition already, and we have discussed quite a number of topics at this meeting, and we're going to talk about that together. What were the highlights of this meeting? So to start with, there were presentations on early detection of lung cancer. And what is your take-up of that? What is the key message of the early detection strategies in lung cancer nowadays?
Well, as you know, in the last few years, we got the results of an important randomized clinical study that has been conducted in the United States that showed a marginal benefit by using CT scan as a screening tool for early detection of non-small cell lung cancer, of lung cancer in general, but it's mainly for non-small cell lung cancer. Well, the critical issue about that specific study is to compare the results, the positive data from that study with the, let's say, questionable results coming from other smaller studies with a prolonged follow-up. The US study up to now has not enough follow-up, or let's say an extended follow-up, to show that there is a long-standing duration of the benefit of early detection. That is something that came out from other studies for which we have already available a prolonged follow-up. Consequently, the use or the systematic use of CT scan as an early detection tool for the general population is not still there, because obviously if we acknowledge the role of this diagnostic tool, we should offer this diagnostic tool to everyone, and that is really a big societal issue in terms of finance. The other point is that these kind of results were obtained in highly motivated subject population. That is not true for the overall population of smokers in every country in Europe as well as in the United States.
So it's still too early to say this is standard practice. Every smoker or every past former smoker should be a candidate for a screening study.
Well, I believe that the guidelines or the recommendations that are done by different scientific societies, including also the International Association for the Study of Lung Cancer, that is a sort of reference society for these people working, for all of us working in thoracic oncology. I believe that the recommendation how to interpret these results in stating that the CT scan, the low dose CT scan, is not still recommended as a routine early diagnosis tool is probably the most appropriate way to interpret this kind of results.
What do we need to get to a level that screening is going to be part of the daily practice?
Well, first of all, probably we need to select in a more appropriate way those patients that not only because of the tobacco exposure or the protracted tobacco exposure are considered at high risk of lung cancer, because obviously the general concept is the following. Only 1 out of 8 heavy smokers are getting lung cancer during their lifetime. And consequently, there is something else that is relevant. It could be at genetic level. I don't know. It could be that the proteomic will tell us something using the sputum or using any other biological fluid. Now, there is a line of investigation that is telling us that probably the microRNA could in some way help us to anticipate the time of diagnosis, even for small lesion in the lung. But this is something that came up from 1 or 2 reports. And again, this is still another investigational tool that need to be validated in the context of prospective studies.
Okay. And for so far as the data are there, is it possible to describe which population is benefiting most? Are that the former smokers, or still the current smokers, or are that the ones that stop smoking while they are participating in the study, or are all these questions still unanswered?
Well, it's still a big question mark. Obviously, we know from the epidemiological studies that if you quit smoking and you are quitting smoking very earlier, probably in a period of time of 10 to 15 years, your risk of getting lung cancer is probably almost equal. It's not exactly equal of the risk of never smokers. And consequently, it's quite likely that the light smokers who quit smoking, or in any case, all those people who decided to quit smoking are those that quite likely are benefiting more from this kind of intervention. But the real threat is another. And from my personal experience, doing a relatively small study in high-risk subjects, we were following this cohort of subjects also with a smoking history questionnaire. And when they decided to participate to the program, almost 1/3 of this subject decided to quit smoking. But in a couple of years, when they were informed that the CT scan was normal, they unfortunately restarted the attitude. And unfortunately, after 5 years, only 7% of the patients were quitting smoking, even if we were offering a program.
So screening without a very strong supported anti-smoking program is not
doable. It's not doable.
Okay. Okay. So despite the fact that it's not standard treatment, what we now see, and that's also due to the improved techniques of detection with a higher higher resolution of the CT scans, we see a lot of small lesions in the lungs. Ground glass, solid, part solid, and having found a diagnosis in this, what is the best treatment for these small tumors? Is that surgery, radiotherapy, wait and see? What do you think is the policy?
Wait and see is not a logical solution. It could be a logical solution in the context of this relatively small. When I'm saying relatively small, everything is quite relative. But I'm talking about ground glass opacities that are newly detected on a CT scan. They have a size inferior to 1 centimeter. They don't have any solid component inside the lesion. They are really ground glass opacities.
So then it's fair to wait.
It's probably wait and see for a short period of time.
Okay.
Is a reasonable solution. But you need to follow up this patient by CT scan every 6 months. If you have a small lesion with a solid component and this lesion is exceeding 1 centimeter, I believe that surgical resection in general, independently from the way in which you are making the diagnosis of lung cancer through CT scan and early detection or through conventional diagnosis, I believe that surgery, radical surgery, is the mainstream.
So that means for these patients that they have to undergo a lobectomy?
Well, this is another open question that came to us because of these early detection studies. There are two ways of thinking. One is still to perform anatomical resection. That could be either lobectomy or segmentectomy. There are others that, especially in patients with poor pulmonary functions, they are looking to atypical resections. But let's go back just to segmentectomy versus lobectomy. I believe that probably this is something that should be carefully investigated in a large prospective surgical study, because obviously, especially if the individual is continuing smoking, there is an extremely high risk of getting a second cancer. And we know from all the epidemiological studies that this risk is 10 times higher in this category compared to the general population of current smokers.
Could you give a kind of percentage for how many, let's say of 100 patients with a small lesion, how many will have a second primary within a year or so?
No, well, the proportion in a short period of time probably is extremely low.
Let's say then 5 years.
In 5 years, it's something around 4 to 5%. And obviously, more you are moving away from the primary resection, higher is the chance to get the second primary. One of the, let's say, basic rules to define a second primary is the different histologies. Also the fact that you are making a diagnosis 3 years after the first diagnosis of lung cancer.
Yeah, but okay. That's one aspect, so the small lesions and how to be treated. Another aspect is that a lot of these people have more than one lesion already at the time of the high-resolution CT scanning. So what to do then? Do you do 2 lobectomies, 2 wedge resections, or segmentectomies, or?
Well, there is no definitive rule for that. Obviously, I'm thinking about a patient with a small lesion that is getting lobectomy, and after a couple of years or 3 years is getting a new lesion in the contralateral lung. And this is the case in which stereotactic radiotherapy could play the role. And far away from now, if we are just looking into the future a little bit, probably we need another study comparing radical surgery versus stereotactic radiotherapy in the setting of these tiny solid lesions, even limiting the study to those lesions below 1 centimeter. And this is really an important, from my point of view, is an important.
I know these studies have been started, but they all stopped because the accrual was too low. But maybe a different approach could be that they do it in the second primaries, because then is the chance that the surgeon will go in again with a lobectomy is probably smaller, less enthusiasm for that. What do you think about that?
Well, it's a win-win situation because unfortunately, we are getting a huge number of new diagnoses of lung cancer. So there is enough patients to be resected by the surgeon. There is enough patients to be treated by stereotactic radiotherapy. But and I'm just trying to be easy on this issue. But I fully agree with you that we need to, in the interest of our patient, we need to know if it's better to resect the tumor and take it away, or to irradiate the tumor with an high radiation dose, because probably the story will be repeated over time.
Okay. So having said all this about early detection and early stage treatment, there's probably a lot more to be said, and there will be said in the future. Let's move to a different target and a different topic, and that is the molecular diagnosis in lung cancer. So there's a lot going on in that area, and it's now 10 years since the EGFR mutant patient was detected and the therapy was there. So after 10 years after this discovery, where are we now?
Well, we made progresses in addition to that, because the EGFR mutation story was really the entrance door for the molecular diagnostic of lung cancer. After the EGFR story, we got another important story, that is this 3% of patients, 3 to 5% of our patients with adenocarcinoma, that they are harboring an ALK translocation.
Okay.
And this ALK translocation is not completely new in the field of oncology, because we have also a tiny minority of anaplastic lymphomas that they have an ALK translocation, and the ALK translocation is progressively identified also in other type of tumors. But coming back to lung cancer, we have this 3% of adenocarcinoma with the ALK translocation. We got a specific inhibitor for this ALK translocated tumor that is called crizotinib. In addition to that, crizotinib is also working on another extremely rare translocation, that is the ROS1 translocation, that could be detected in less than 1% of our patients with an adenocarcinoma diagnosis. Overall, without playing too much with the numbers, we can say that among the Caucasian patients, these kind of genomic abnormalities account for, let's say, something around 10–15% of our patients with non-small cell lung cancer. Well, the bulk of evidence that has been collected over the last 10 years is telling us that for these two molecular abnormalities, if you are treating the patients with the right targeted agent, you are able to improve the progression-free survival. You are also able to extend survival of our patients. And this is something that was completely ignored before 2004, because for patients with stage 4 non-small cell lung cancer, the median survival time was inferior to 1 year. For these patients, the median survival time is already exceeding 2 years.
Okay, so having said that, so we have let's say a kind of first generation drugs for these targetable abnormalities, so these mutations or translocations or whatever it is. What is the status of the development of drugs in this area? Are there, after gefitinib and erlotinib and crizotinib, are there new drugs at the horizon?
Well, yes. Starting with the EGFR inhibitors, we got already information, unfortunately, let's say only marginally positive, about the use of irreversible EGFR TKI, because one of the irreversible inhibitors, afatinib, has been just recently registered for patients with EGFR mutations. But if we are comparing the toxicity profile of the reversible EGFR TKI versus the irreversible EGFR TKI, probably for the latter, there is an amount of non-hematological toxicities that is slightly higher, and consequently this is something that we need to learn how to deal with. More importantly, we need to stress the fact that even if these first generation agents are able to extend the progression-free survival, sooner or later the patients are becoming resistant to EGFR TKI, and the spectrum of the mechanism of resistance is quite huge, and is huge for EGFR mutants and also for ALK translocated patients. Consequently, now we are looking and we are seeing at the horizon that there are third generation EGFR TKI that are targeting specific acquired resistant mechanisms, like for instance T790M mutation, as well as for the ALK translocated tumors, we have a second generation of ALK agents that are quite active, that are active also in those patients who were pretreated with crizotinib, and they are also active in those patients that they have brain metastasis, having an ALK translocated tumor.
Okay, having said that, what does that mean for the daily practice of a physician who is seeing a patient suspected of lung cancer? What should be the testing?
Well, this is really a critical question, and we need to be really straightforward in making our answer, because I believe that is a professional duty of every physician involved in the field of lung cancer, to maximize the molecular testing for all the patients with a newly diagnosed non-small cell lung cancer with non-squamous histology. It means that every patient with this kind of disease should be submitted for molecular testing, at least for the EGFR mutation and the ALK translocation. For ALK, but also for the translocation of ROS1, probably in a second step. Because there is clear evidence that has been presented last year at ASCO, that if you have a driver mutation and you are getting the specific targeted agent, you are improving your survival expectation.
So this is at first line. So it's not at relapse. This is really at first line.
First line. But I'm pretty sure that if you are missing the chance to offer this kind of treatment in front line, that you should do everything possible to give the frontline treatment to your patients. Even if you are missing this chance, even if you are considering to give the targeted therapy in second line, the targeted therapy is always able to modify the survival expectation of your patient.
Okay, so those patients who are harboring these mutations, they are really the ones that need these drugs?
Absolutely.
Okay, good. You already said this is a rather small subgroup, about up to 15% in the Caucasian population. That brings us to the other 85%, which is different, which do not have these driver mutations. And what is the status of the treatment for those? Let's start with the ones who are not metastatic outside the chest, so they are potentially candidates for combined modality treatment with a local and a systemic treatment.
Well, for this tiny minority, unfortunately, tiny minority of our patients, because again, we are talking about 10 to 15, no more, of our patients, at least in my personal experience. For those patients with performance status 0-1, without significant comorbid conditions, the standard of care is concurrent chemo and radiotherapy. If you are dealing with a relatively old patient, let me say over 75, with a significant level or a significant degree of COPD or with pulmonary fibrosis or whatever you want, probably the sequential treatment, starting with chemotherapy and then following with radiotherapy, is probably the best solution. This is something that you need to take into consideration when you are planning your treatment, because always the trade-off between the activity and the toxicity is relevant for our treatment decisions.
Okay. And we're talking about a lot of elderly patients, isn't it?
Yeah. Well, the average age at diagnosis is getting close to 70, so consequently it's something that obviously the academic position is concurrent chemo and radiotherapy, but there are a lot of caveats that should be considered in making your decision in your daily clinical practice.
Okay, and having said these combinations, what is the backbone of the chemotherapy for these patients? Is there any news in that?
There were several attempts to switch the backbone chemotherapy away from cisplatin etoposide, but cisplatin etoposide is still, let's say, a commonly used backbone chemotherapy for these patients. Obviously, we got also data using the combination of cisplatin pemetrexed concurrently with radiotherapy.
That is safe?
The combination is safe, the approach is safe, but the outcomes in terms of efficacy are not definitively better than the older one.
So the standard remains the relatively old combination platinum etoposide?
Let me say that it's not unethical to use a different one.
Okay. But it's also not unethical to use a more modern combination like cisplatin and pemetrexed?
Yes.
Okay. Then let's move on to, having said this about combined modality, what is the situation in stage 4? So those who are candidates not for on mutation-based therapy like EGFR or ALK or whatever, no, just simple those without a driver mutation. What is the treatment? What is the most important thing to be done by the physician before they start a treatment?
Well, there is a lot of genomic search for squamous cell carcinoma, but for squamous cell carcinoma, the standard of care is still a doublet chemotherapy using cisplatin or carboplatin as a backbone, according to the individual physician choices. On the other side, for non-squamous, there are essentially two major opportunities. One is related to the use of pemetrexed, because pemetrexed showed to be superior to cisplatin gemcitabine. Obviously, there is no direct comparison, for instance, between cisplatin, pemetrexed, and cisplatin and taxanes. But obviously, what is probably making the difference is the extremely mild toxicity profile of cisplatin pemetrexed. This is again, my personal experience, my personal opinion. The other important opportunity is represented by the use of the anti-angiogenetic therapies. And when we are talking about anti-angiogenetic therapy, we are talking mainly about bevacizumab that is usually administered together with carboplatin and paclitaxel, as has been done in the registration study that proved to be the superiority of the triplet combination over the doublet.
So that is for the non-squamous. What's the standard for the squamous?
The squamous, as I said before, there is nothing new in addition to a doublet combination, and again, any doublet including carboplatin or cisplatin. My personal choice is for cisplatin gemcitabine, but I cannot deny that other physicians are using a different combination, in any case including carboplatin and cisplatin. There is, in addition, this information that came out as a sort of subset analysis from the study which investigate Abraxane in combination with carboplatin and cisplatin in frontline, a typical US study that showed only for response rate, not for PFS and not for overall survival, a superior efficacy of Abraxane and platinum in the squamous cell carcinoma.
Okay, but that is too early for registration yet.
Well, it's too early. For me, it's not enough to claim any superiority.
So for now, we come to the end of the presentation. For now, the end of what were the highlights of the Perspectives in Lung Cancer meeting in Amsterdam. We will continue in the near future about what is going on in this area. Thank you all.